Hello, everyone. I'm very happy to welcome you to our journal club tonight. And I'm even more happy that tonight Germany is selected as guest nation. So even if soccer was not working that good, we are hoping that we are much better in research and journal clubs. So may I shortly introduce myself? My name is Leila Harhaus. I'm working in Ludwigshafen, which is kind of close to Frankfurt, to the big airport. And there I'm leading the hand unit. And I'm very happy to have with me as editor from our JHSE, Mike Rütterman from Groningen. And then our second host is Jonathan Hobby. He is with us from the UK, Basingstoke. And from Germany, Ariane Asmus. She is expert number 1. She's from BG Trauma Hospital in Berlin. And expert number 2 is David Ring from Austin, Texas. We are very happy to have you with us tonight. And then we're coming to the authors. We have Kay Madison, who is the author of our first paper. And the second paper is just coming from Japan. And since they have 4 o'clock in the morning, so they cannot join us, but Mike will be so nice and take over the discussion on behalf of them. And then we have our 2 fellows who are just introducing the papers and giving a short summary. We have James Kennedy from Edinburgh and Kohilavani Sigamone from Wrightington. So let's lose more time. Let's start with the first paper, and I may hand over to Jonathan Hobby, who leads the first paper for you. You are muted.
So the first paper is on the psychological effects of hand trauma. So we'll start with a presentation.
Hello. My name is Kahila Sigamani, and I am going to talk about a very interesting paper titled The Psychological Sequelae of Hand Injuries and an Integrative Review by Madison, Perry, and De Bono. I am currently the Training Interface Group Hand Surgery Fellow at Wrightington. So the authors have very clearly stated that there is a gap in literature on the psychological impacts of hand trauma. And they've asked 3 very pertinent questions. So firstly, which psychological sequelae can accompany a hand injury? At what time points in relation to the original trauma or surgery do these occur? And which factors have been reported to influence the psychological sequelae development type and intensity? The outcomes that were in the studies that were reviewed were of used multiple tools, and this is level 3 evidence. It is an integrative review. So hand injuries vary widely in severity and result in a range of reactions from our patients. However, Bates and Mason define major hand injury as a permanent alteration in function of the hand through sudden or accidental actions. And the consequences can be both physical and psychological. So the authors used a combination of evidence to do this integrative review. They searched multiple databases, and the search terms that they used came from 3 different groups. So the first group is a term in relation to where the injury was in the upper limb. The second group was about the psychological sequelae itself. And the third group was the word outcome itself. So it gave a huge return of articles to the authors. The inclusion criteria was adult studies of original research in English, published from January 2008 to June 2020, focusing on psychological outcomes and impacts on one-sided traumatic hand injury, so unilateral. The exclusion criteria were those of discussions of non-traumatic pathology like degenerative conditions, studies where pain was the outcome measure, and studies that talked about polytrauma or multiple injuries like war injuries, and that discussed work compensation. In the end, there were 9 articles that were suitable to be reviewed, and each article was appraised by each of the 3 authors. The findings were compared and discussed and agreed upon. And in the supplementary material, it is noted that the authors have documented certain things like the author, the country, the demographic of the study, demographic of the injury, and follow-up methods. The findings from each of the paper in response to each of the 3 questions was also extracted, and then they used this narrative synthesis approach. So a narrative synthesis approach is a common approach to the synthesis of data in studies like systematic review. It's used where statistical or other methods, formal methods of putting data together is not possible or appropriate. But then it's not just about summarizing data from each of the papers, it's about investigating the similarities and differences between the studies, and then exploring the relationship of the data and summarizing the knowledge available. So if we look here, this slide, there's a lot of acronyms. These are all validated questionnaires that were used as outcome measures in, patient-reported outcome measures in the studies that were involved. I draw your attention to some that were used in a few studies. So the DASH score, disabilities of arm, shoulder, and hand, was used in about 3 studies. It was more of a functional assessment. And then we've got the Michigan Hand Questionnaire used in, again, 3 studies. And that was a functional assessment measure, but with also assessing the psychological impact. And thirdly, I'll draw your attention to the impact and event scale used in 2 studies. This 15-item questionnaire actually focuses on PTSD type symptoms, including intrusive thoughts and avoidance. And that's quite important. So as I mentioned, there were 9 studies. So they were prospective quantitative studies, all from the Northern Hemisphere. They reported predominantly male patients, early to middle age. However, one study reported that women were more at risk of psychological sequelae. And all the injuries were distal to the elbow, mainly occupational injuries. And the injuries mostly caused pain that affected the lives of patients and impacted their functional abilities. Follow-up timeframes for the 6 cross-sectional studies, the follow-up was 1 month to 27 years post-injury. And for the 3 longitudinal studies, this varied. They had different follow-up intervals. So in response to the first question, so the types of psychological sequelae in hand injury, there were 3 types reported. So depression, which was reported in 6 articles. The range or the percentage of patients suffering from depression varied from 19 to 32% of severe depression. PTSD, so post-traumatic stress disorder, reported in 6 articles, and 2 articles actually said that 30% of patients screened positive for PTSD type symptoms, and they would have more symptoms if they were having pain. And then there was anxiety. Again, the reports varied. So there was 23 to 71% in different reports. However, 15% of patients had severe anxiety, and 43% of patients suffered severe anxiety following an amputation. This table may appear a little small, but it's table 2 from the published paper. I want to draw your attention to the red box. So that's the reports on PTSD of unspecified severity. There were 7 papers that mentioned it, but 6 reported it. And we can see that this is quite an important condition to recognize in our patients. The psychological sequelae that happen were concluded by the authors that it can happen in diverse hand injuries. Doesn't mean that it only happens in major hand trauma. It can also happen in mild hand trauma. In response to the second question, where we were looking for time points for psychological sequelae in relation to the original trauma or surgery, none of the articles provided this information. However, they talked about prevalence rates at various points. So Alti et al. In 2013 mentioned that 93% of patients had stress symptoms at 1 month, and this decreased slightly to 83% at 3 months post-injury. Gustafsson et al. Stated that 24% had psychological symptoms at 1 week post-injury, and then 8% had them at 3 months. The 8% persisted for about a year, and after that it improved between 1 year and 10 years to 2% at 10 years. And in response to question 3, factors influencing the development, type, and intensity of psychological sequelae, there were many. So mainly functional loss and pain, and the degree of functional loss and the degree of pain correlated to the severity of psychological sequelae. Time was another factor. As time passed, the symptoms of psychological sequelae started to subside. However, patients who had ongoing physical or social or body image issues, they tend to continue to face the psychological sequelae. And as I mentioned, one study said that females were more at risk of struggling with psychological sequelae post-injury. So in conclusion, the included studies reported common psychological health effects in hand injury. What is interesting is that the findings or the reports in this review is comparative to findings of the Australian study on mental health sequelae of any form of trauma, which actually tells us that hand trauma can bring about psychological health effects that are as severe as any form of trauma. There were limitations, so the sample size of the studies included varied from about 8 to 118, and due to the variability in study designs, it was difficult to make conclusions. Also, the outcome measures were all objective assessments, and in a topic like this, it's important to have qualitative records of patients' experiences. But I must stress that these are not the limitations of the integrative review. Sorry, these are not issues to do with the integrative review itself. It is more related to the available literature that are out there. But the authors have done very well to summarize the knowledge available on this important topic. So what does it mean for my practice and patients? I think that I have a big realization that psychological sequelae in hand trauma is as significant as any other traumatic injury. And I recognize that my patient progress may be affected by mental health. And I have an appreciation of hand therapist work. And I think that patient education and access to psychological support is very important. So my questions to the authors are, how do you propose we identify patients at risk of psychological sequelae following hand trauma in our practice, and what can we do to help these patients? Thank you.
Thank you very much, Kavani. A very good summary of a very interesting paper. So I think, as you say, this has really raised people's awareness of the importance of psychological factors, so post-traumatic stress disorder and anxiety and depression in patients' recovery from hand injury, and also indicated that this is often a self-limiting thing in many cases, but there are things we can do to help patients as long as we recognize it. So, Kay, do you want to have a stab at answering Kavani's questions in terms of how do we identify it and what can and should we do? And I'll throw in a little spinner, which is how effective is intervention, if you can comment on it.
Thanks, Jonathan, and thanks, Kalani. Thank you for that review. So yes, I think for all clinicians, it's to be aware that there are the potential for patients to have psychological outcomes following hand trauma, and it's not reliant on the severity. I think we all assume that the complex, the bigger the injury, the potential for mental health problems following that injury is possible, but I think we have to realize that it could happen to anybody. And I think having that awareness, just having conversations with people, you've got the patient in front of you, having those open conversations, asking simply, how are you? How are you going? And not just focusing on the hand and the outcome of the hand and the recovery. It's just how are you going in general? We have to, I think there's a lot of work about reducing the stigma associated with mental health, and we almost have to normalize what is happening and the feelings that people are receiving and are experiencing. And Jonathan, I think your question, what can we, I think that's a tough question that you posed. So while I'm thinking, I might hand over to the experts, David and Ariane, and I'll come back to you.
We will hand over to David and Ariane in a second. I'm going to put my oar in a little bit further in that I think a limitation of this review is that we haven't been able to do any form of data synthesis, which would be helpful in terms of having an understanding of how common this is. The range is very wide. I think one would anticipate that post-traumatic stress disorder is a consequence of the injury. With anxiety and depression, they're both quite common in the general population. So some of that may be pre-existing, although it's clear if somebody injures themselves and can't work and worries about their career, that certainly is likely to exacerbate anxiety and may, if they can't find their way through it, precipitate depression.
I think you're right there, Jonathan, and I'll just jump in and looking at the Australian population of where I'm located, about 1 in 6 people in the general population aged 18 and above have a history of anxiety, and about 8% of the population in that age range have a history of depression. So it is prevalent in the community, like you say. But yes, we are limited to, we have been unable to provide any synthesis in relation to that.
Well, I think at this point, I should hand over to somebody who actually knows what they're talking about. So David, what's your view of the paper and the questions that we've raised?
I really like what you've already brought up, and that, you know, Kay's emphasizing that if you have a hand injury, no matter how bad, it's disruptive to your life. You may worry about your roles and identities and may feel a little worried or despairing. We also know that the human mind encounters pain or blood or all the kinds of things that go with an injury and feels very protective and vulnerable. And we see that in people. We try to say, hey, moving your hand is going to be good for you. And they think we are crazy because it hurts and it's swollen and it's mangled. And so getting them past that counterintuitive autopilot mind or first guess at what is the right thing to do towards what is actually healthy is tricky. And you've also brought up the issue of mental health stigma, which is the main thing in the way of helping people, taking care of the whole person and giving them comprehensive care, is the potential for offense. And it's not just how we say it or what we say, but the whole idea of asking somebody to rethink what their mind is telling them, or even pointing out that their mind it tells stories and isn't perfect, is a relationship threatening moment in every case. So the normalizing and connecting that Kay talked about is the key thing in relationship building. If I look at the paper itself, I think, you know, when you do a systematic review, you're stuck with what's out there. I think we need to get away from looking at mental health diagnoses and look at elements, any level of symptoms of despair or anxiety, and stop trying to categorize or dichotomize, because those categories reinforce mental health stigma. We should anticipate worry, despair, misconceptions, be prepared with communication and relationship building strategies. And I already heard one of my questions was answered by Kay, which is, in her review, she didn't think that the severity of the pathophysiology or the injury was important, and I agree. Our data shows the same with rotator cuff. For instance, the size of the defect, muscle atrophy, fatty infiltration doesn't seem to make a difference. We have unpublished data on carpal tunnel. The severity of the neurophysiological abnormalities don't seem to affect comfort and capability very much. It seems to be much more mindset issues. So my question for Kay is occupational, physical, and hand therapy going to evolve towards cognitive functional therapy or psychologically informed therapy, where we understand that the key thing we're doing is helping people get in a healthy mindset that allows them to do exercises that are otherwise relatively simple?
Thanks, David. Unfortunately, I'm not a hand therapist, I'm a nurse. So that, answering that question may be a little bit tough, but I think so. I think we all have to evolve. And certainly in my practice as a nurse, I'm more aware, and I have those open conversations with people from the very beginning. And it's often myself who is with the patient long after the surgeons have left the room, after we've looked at the wound and gone, oh, that looks great. When the patient's looking at the hand going, are you kidding me? It's a mangled mess, like you said, David. So it's, I think we've got to evolve. All of us as a multidisciplinary team working with these patients, I think we all have to evolve and look at those cognitive factors that during our therapy, during our intervention with those patients, we have to incorporate that the psychosocial response and how we can actually help these people.
So that's great. Thank you. I've been discussing this in some detail with occupational therapists for a little while, and they assure me that actually psychological factors are really important in the training of occupational therapists, but perhaps less prevalent in the training of physiotherapists. So there are many hand therapists with an occupational therapy background who have a good grasp of this. Now, we know, or I know, mainly from David's research, that this really does affect outcomes, and patients who have severe psychological distress following hand injury do less well in terms of rehab. Their outcomes are less good. And he's given us some great advice in terms of what we should do with when dealing with these patients. David, I've got a little checklist of what I think you've told us we should do, which is basically listen, so you understand and validate their experience, build a relationship, and then reassure and educate. Would you like to build on that at all?
Yeah, it's like what Kay said. It's not just the therapist; it's all of us on the team that need to get good at this. And you're going to have to tell somebody to move their hand when it feels like they shouldn't. And to do that, to accomplish that, you're going to need trust. And to gain trust, you're going to have to make sure the person before you feels heard and understood. And it's really as simple as that. And it's very, very hard to reorient people's unhelpful thinking. And what happens there is there's these automatic thoughts, we all have them, but some people fuse with those thoughts more readily and more strongly than others. The thoughts feel like facts. And that the evidence is showing that it feels more like a fact than a possibility under symptoms of anxiety and depression or social stressors like poverty or job stress. And it's just harder to move off that initial thought. And so we need to be recognizing how difficult it is, being patient with it, and emphasizing trust and the relationship. And we can guide them and teach them how to do the exercises, but it may take them days or weeks to figure out that it is healthy and really prove it to themselves in a way that, and we've all seen that happen, right? We've seen the very stiff finger, and then, you know, a couple weeks later they come in, they're doing great, and they sometimes they'll say, like, I realized these fingers weren't going to move themselves, or something like that, or I did it like you said, and at first it felt like I was going to rip everything apart, but then I noticed I was moving better. And so we just have to be patient with it. I'll say one other thing about, you were asking about evidence of what we can do. I think the key things are what we're talking about: relationships, communication skills, normalizing, guiding patients, and understand and expecting and anticipating this. But there is some evidence. I think most people, everybody has a little bit of catastrophic thinking, worry, and despair. And I think a lot of people find their way through it. But when you get at these very high levels, there is growing evidence now that intervention can help. The question is, what intervention will that take? Workbooks and other things have not shown good evidence, but the toolkit, which involves cognitive behavioral therapy by a trained, someone who's trained, I think there is more evidence around that. And I do think the reason I mentioned the therapists is I think a lot of what, at least in the United States, a lot of what hand therapists do and occupational therapists do probably isn't very valuable, and probably it isn't very evidence-based, just like a lot of what surgeons do. But I think if they could develop this aspect of their practice, they'd be right in line with the evidence and doing just exactly what patients need.
Ariane, I'm going to ask you for some comments. We've got a couple of questions from the audience, and I'll get Mike to sum up why he took this paper before we close in 2 or 3 minutes' time.
Okay, just, yeah, I think it really starts at the beginning when the patient comes into the hospital right after he got operated, and you've had a sense or a feeling how the patient is coping with it. And we are lucky in our hospital that we have a psychologist at hand that helps the patient to prepare for the first undressing of the wound. Yeah, that it's going to be in a, yeah, they prepare them, and then we come as a doctor, and then we tell them what to do, and they tell us what to do. So we are real lucky to have them. And they also have a big part in our rehabilitation program from hand injury patients. But still, it's a problem, and it's a very important topic. And I'm really glad you did what you did, the effort you made. And I thought it was, I think you mentioned about 21 questionnaires. You had to look at different questionnaires, and still you just couldn't answer the 3 actually simple questions you wanted to know. And I wonder what you think of now. Do you have any advice for future studies, advice for your own practice, for us, what to use? Did you find any of those really good and useful? And secondly, also to your second question, you talked about when the time frame, when was anything happening, when was the psychological problem coming? And that's a very difficult question, because also the therapists, they hardly can tell that, and you don't know what is under the surface and when something comes up. And you think that those follow-up studies, I think there were only 3 of them, were they more informative for you? Were they better than the others? I think they have to be follow-up revisions of the patients, and not just one single kind of time frame that they are looking at. So,
thanks, Ariane. I'll answer a couple of your questions. I know time is short. I think for my own practice, it's become very aware that we do need to do more. But I think looking at the studies that were included in this paper, they were using tools, measurement tools, and not actually talking to the patient and not hearing the patient's experience and gathering that. So that's where I'll be heading to next, and that's the next part of my research. And I think that's important. Measurement tools are great, but it doesn't show the whole spectrum of what the patient's experiencing. And like David said, it kind of is challenging for the patients to actually feel quite confrontational measurement tools when you're kind of focused on a particular outcome. So yes, for my own practice, I think it's important to listen and to hear what the patient is telling you, and that's just exactly what David just said.
I mean, I think that's a nice point. Sometimes asking somebody to complete a psychological questionnaire puts them in mind that, do you think they're mad, which is not helpful. So Andrei Lisak from Ukraine has asked, is there any correlation between psychological stress after trauma and the development of CRPS? I mean, my reading of the literature, I believe that there is, but my reading of the literature is that there's no evidence to support that. The studies have suggested that assault or workplace injuries or road traffic accidents are risk factors for PTSD at least, and also young age and female gender are relative risk factors. So I assume the fact there's a preponderance of males in this suggests they're just more likely to injure their hands. The second question is from Peter Chinesky, which is, what's the role of family support of patients with these problems, and probably wider support networks? So David, that's probably your thing. Presumably it's important.
Yeah, the family networks, absolutely. Yeah. I mean, the family support can either reinforce unhelpful mindsets or help alleviate them. And I think just knowing that you have support and the security of that support makes it easier to be flexible in your thinking and start to do painful exercises. And one simple answer to the CRPS question is, CRPS is a theory that posits a underlying pathophysiology, but nobody's ever identified a pathophysiology yet. But if you talk about pain catastrophizing and look there, you can find what you need. So it may be a biomedical conceptualization of the mental health.
It may be, but that's a whole new debate, which could take us another half an hour.
So they need to hear it, though. They need to hear it.
They've heard it. So we're a minute or two over, so I'm going to ask Mike to summarize his thoughts on the paper, why he accepted it, and what he thinks of our attempt at criticizing it. And then from there, we'll hand over to Leila to introduce and manage the second paper. Thank you all.
Yeah, thank you very much, Jonathan. I think from the discussion, we already had an impression of how important this topic is. And the author started out as a systematic review, which unfortunately the literature was not sufficient to do. So that's when we switched this to an integrative review. And the big advantage of this study is that they really searched all the databases, also the psychological ones that we normally overlook as hand surgeons or surgeons in general. And they really crystallized this fact that we sometimes miss as clinicians, especially surgeons, when we look at a trauma, a minor trauma, and think, oh, it looks well, and the patient is basically catastrophizing and getting into a psychological distress. So we have to be aware of these minor injuries that are causing the patient's trouble. And I think this paper helps us to realize this. And you heard a lot of good approaches in the discussion on how to deal with this. And maybe the therapists are our biggest help in this fight against psychological issues with the patients.
Okay, Thank you very much for this summary, and thank you for this more than interesting discussion on the first paper. Now we are heading to the second one, which is less interdisciplinary, let's say, and pure hand surgical paper. And James Kennedy from Edinburgh in UK is going to present it to us.
It's good evening. My name is James Kennedy. I'm the Edinburgh TIG Hand Fellow. I'll be presenting this paper by Murayama and colleagues from Japan on volar plating versus external fixation for unstable dorsal fracture dislocations of the proximal interphalangeal joint from the Journal of Hand Surgery 2022. The authors introduced the paper. Excuse me, the authors introduced the paper discussing the difficulty in management of these complex injuries. The comparison was between external fixation and volar plating. The outcome measures included range of movement, patient satisfaction, and bony union. Data was collected retrospectively, comparing between the two cohorts, making this level 4 evidence. The paper notes that this injury commonly results in stiffness, pain, and osteoarthritis. The authors discussed that many techniques exist for the management of fracture dislocation of the PIPJ, including closed reduction internal fixation, ORIF, X-fix, volar plate arthroplasty, and the hemihamate procedure. But there is little evidence to suggest the superior method of management. Thus, they raise the question, which approach yields better results, external fixation or volar plating? This was a single-center cohort study where data was collected retrospectively over a period of 11 years and performed by 6 surgeons. 31 patients were included based on the criteria of a central depressed fracture at the base of P2 with greater than 40% articular surface involvement and with a minimum of 6 months follow-up. 15 patients were excluded citing no depressed fragment, adjacent to digital fracture, or concomitant digital fracture. The authors described their surgical technique in detail. Open reduction internal fixation was performed following a closed reduction with a dorsal blocking K-wire. A Brunner incision was utilized with release of the A3, C1, and C2 pulleys. FDP was retracted and FDS incised to achieve access. The volar fragment was elevated and bone graft inserted. A T-plate was used in a buttress configuration. For dynamic external fixation, a mid-lateral incision was used. The collateral was detached from the proximal phalanx, and again the volar fragment was elevated and bone graft inserted. Percutaneous fixation was achieved with 0.7 mm K-wires. The collateral was reattached and an external fixator applied through the center of rotation of the proximal phalangeal head and the middle of the middle phalanx. Rubber band traction was applied. In both surgical techniques, patients commenced active rehabilitation from day 1 post-op. At 2 weeks, passive rehabilitation was utilized, and this was intensified at the 4 to 6 week mark. In the external fixator group, pin site care was performed once per day, and an X-ray performed every 2 to 3 days in the first week. The external fixator and K-wires were removed at 4 weeks post-op. The study period was from January 2006 to December 2017. The age, sex, digit, percentage of joint involvement, delay from injury to treatment, mechanism, and follow-up duration were recorded. The outcomes included the active range of movement of the PIPJ and the DIPJ. The hand 20 questionnaire was used to assess pain and disability. Bony union was recorded. A grip strength ratio comparing to the contralateral limb was determined, and any complications were recorded. The follow-up period was recorded, and a minimum of 6 months was necessary from the inclusion criteria. The paper states that CT was obtained preoperatively, but it does not state the number of patients who had a CT. Plain radiographs were obtained postoperatively up until the last follow-up appointment. The statistics presented were descriptive. As stated, 31 patients were included, with 12 cases plated and 19 undergoing external fixation. The patients were predominantly male at 87%, and the ring finger was most commonly injured, closely followed by the index finger. The majority of these injuries were sustained in sports, and this was followed by falls. Both the joint surface and time to surgery were similar between the two groups, with means of 52 and 55%, with a range of 40 to 80% of the joint surface, and 9 and 8 days to surgery, with a range of 2 to 28 days and 2 to 25 days. The follow-up had a mean of 35 months in the Volar plating group and 40 months in the external fixation group, but I would draw your attention to the range of follow-up being between 6 and 129 months. The authors present the flexion extension values for both the PIPJ and DIPJ. They draw attention to the extensor lag in the DIPJ external fixator group. The arcs of each joint were greater in the Volar plating group as compared to the external fixation group. The hand 20 scores were also similar between the two groups at 9 and 11. Although the authors report an equal time to union, the surgical and rehabilitation time were greater in the external fixation group. The grip strength ratio was similar, but most notably, there were 6 complications in the external fixation group compared to 1 reported in the Volar plating group. Overall, there was a 22.5% complication rate in this series, and on subdivision, the external fixation group had a 31.5% complication rate. These included 2 patients with joint narrowing, 1 dorsal subluxation, 1 hypertrophic scar, 2 cases of pin-side drainage, 1 of which required antibiotics. The Volar plating group had an 8% complication rate with 1 flexor tendon adhesion found at the time of plate removal. Additionally, 4 further plates were removed at the patient's request. In summary, all cases went on to bony union. There were similar subjective outcomes assessed on the hand 20 questionnaire. When comparing Volar plating to external fixation, Volar plating yielded a greater total arc, reduced rehabilitation time, and a lower complication rate. The authors conclude that Volar plating is comparable to external fixation for this fracture group. They found the range of movement outcomes to be comparable to the literature and note few comparisons of differing treatment methods. As for the critique, this is a retrospective cohort study. The authors themselves note selection bias as a possible confounding factor and state due to their small sample size, they were unable to provide statistical testing. They also note that with low numbers and differing digits affected, that they are unable to compare the between digits, for example, the DIPJ extension lag in the little versus the middle finger. Osteoarthritis was not an outcome or reported due to the relatively short follow-up period. So finally, the question this raises for me is what treatment modalities do we need to compare? Thank you for your time.
Thank you, James, for this excellent presentation of this topic and of this paper. And yes, also for this last question. I think that we all know this very difficult situations being faced to these kind of fractures and trying to somehow fix them and giving them back the best possible movement and function. And we all know that is not easy. And I'm sure that all of us, we have a kind of little different approaches to treat these fractures. We have just read a paper in the recent JHSE about dorsal block pinning. This was reported from Helsinki. We in Germany, we like to do the Hintringer technique. And maybe I just share shortly my screen with you, because I think it's worth to look at another technique, which is more or less a conservative technique, which is the pool splint technique, which I just want to show you briefly. My colleague from Heidelberg, Benjamin Pansram, is actually doing this very enthusiastic. And it just shows you with this kind of old technique, which is more and more developed nowadays, that with this kind of traction, also this kind of fractures which have less than 50% of healthy joint surface can be managed and can be rescued. So with your questions, you were more than right to ask whether these two very invasive techniques which were presented there are the right ones to compare, or should we maybe look for many more? So maybe I give this question also to Mike, because he is on behalf of the authors and handled the paper as editor, to let us know a bit more about the backgrounds of this paper.
Yeah, thank you very much, Leila. I think the authors are somewhere around 4 o'clock in the morning in Japan, so they could not join us. But at the time this paper was submitted, there were also 2 other papers from Japan on this type of injuries. And I have to say they did select these cases only from the fatal dorsal dislocations. So not those they would treat conservative too, but those that failed conservative treatment or simple ligamentotaxis with a simple external fixator. So only those they could not manage technically, they put in this study, which is a kind of selection bias, but they could not figure out how many fractures they treated otherwise. The advantage here was that they compared quite a lot of outcomes, and they had decent groups. They are small groups, but compared to other published papers, this is a rather huge group, and they have similar groups in both treatment arms and a reasonable follow-up. They also provided much more X-rays, which we did not publish in terms of print space, but the overall results are very good, given the nature of the fatal fractures, and also given that they have treated those with different surgeons. There were like 6 surgeons over quite some time. So from a clinical point of view, they achieved reasonable results. And their main issue was that it might be worthwhile to use a plate, because basically they came from the external fixator. And then they realized it was not possible to use this without opening it up and putting additional K-wires in this kind of fracture. And then they said, if we have to open it anyway for the external fixator, then we might as well try the plate. And one important thing was that they used it as a buttress plate and did not put screws in the last one. So if you look at the X-rays, the plate is rather proximal, and that's maybe why they took out some. But overall, I think given these fractures, their final results are pretty good. And some of the cases, they had rather long-time follow-up. And as far as they could provide, they did not have arthritis there, but they could not report it because the other cases were too short-lived.
Thank you, Mike. I was also very surprised about these results, and we agree. I think, Jonathan, you also wanted to state that the plate group was the better one, and probably also because of this dorsal wires in the external fixator group, which kind of blocked the extensor tendon and might have contributed to this extensor leg of the VIP. But Jonathan,
comment really was only that it seemed that the results of internal fixation were better in this group from these authors. It's technically very demanding, and it's easy to make a bad situation worse. So I applaud their skill. But that was my comment really for others to reflect upon.
Thank you, Jonathan. Now I would like to ask Ariane about her opinion on the kind of surgery and also on the paper for sure. You are muted, Ariane, muted.
I'm sorry. Now you can hear me, I think. So we are also actually a fan of the dynamic fixation and leaving the joint as it is, keeping the integrity and using the Hintringer-Stößelung. But I have to agree also with Matt, if the joint surface is damaged for, I don't know, over 60 to 80%, you really have problems with the external fixation. And that's the point where you have to think of what can we do actually with the joint. Do we say to the patients, oh, it will be an arthrodesis anyhow someday, somehow, and we just put a stiff external fixation and wait till it kind of settles and then do an arthrodesis or a hemi-hemate probably. But I can imagine why they try to figure a different operative procedure. I don't have any experience with the Volar plates, and I don't know if it might be a good idea looking at the results, but still, I think most of those fractures you can cope with the external dynamic fixation and wait till the joint surface is well enough to take it out again. But that's only my opinion. I'm also very astonished how good the results of this group actually, how good they are. And I'm not so surprised about the bad results from the other group, from the mediolateral opening, detachment of collateral ligaments, reattachment, and the pins. I also think it's the problem of the lateral bands that are pinned down. And that's also something we try not to do and try to avoid with these patients. Do we get anything more about the why the operative team chooses one operative procedure over the other, whether there may be less fragments or more fragments for the Volar plate or the external fixation? Did they tell you anything about that?
I think it was written that they chose by preference of the surgeon, right, Mike?
Yes, indeed. They collected those cases retrospectively because they are really rare. And it's only a selection basically of those in which like simple external fixation did not work, because when they just put in those 2 K-wires, they always had the dorsal dislocation. And that's why they opened them up. And I think in the beginning, they realized the results are not that good. And then they went on to plate fixation. And but that's the selection bias of the study, that this kind of patient did not work conservatively or with a simple external fixation. And then they took it one step further. And in the end, the open fixation came out even better than the extended external dynamic fixation with the K-wires.
Thank you. Jonathan was raising.
Just to raise a question from the chat, Alex Nichols has asked the question, by opening it up, surely they're losing all the advantages of closed management with an external fixator. You sort of addressed that, Mike, but do you want to talk further to that?
Yeah, I think that is that was one of my questions to the authors. In the beginning, they also had statistical workups showing that the plate was significantly better, but we had to take a look at it with a statistical advisor, and they did not have enough patients to really have robust conclusions. But the interesting part is that indeed with the right technique and maybe with experienced surgeons, there is a chance to make these better, but it's absolutely true. If you mess it up surgically, the patient is worse later on. So this is also something that you would have to discuss with the patient. I think some of us would even choose these fractures to just put a pin across the wire, stuff it up with spongious bone, and then let it heal and have the patients move later on. But that's a quite long aspect of treatment with a long range of hand therapy thereafter, and also unsecure outcome. So it remains a problem, and it definitely would be easier if it would work just with a simple dynamic fix X, but that's what the authors answered. These cases did not work. Those who would work, I would completely agree from a clinical point of view, would be better off with just simple dynamic fixation without any additional K-wires.
Sure. And I also think if you think further and you one day have to do a second surgery on these joints, like try to implant an artificial joint, something like this, a replacement, then it's much harder to go back into these joints when you previously did this very invasive kind of reconstruction. This is also something you have to have into your mind. Just in this future context. So we have another question from Lambros Athanatos, probably from Greece. Why was this not mentioned in the methodology, as it changes the context? So this is probably for you, Mike.
That's basically what is summed up by selection bias. They only presented their extreme cases, and then they treated them, or those cases had been treated in recent years in their department with 2 different methods, and they looked at those 2 different methods. But indeed, this paper does not say anything about mild fractures of the PRP joint or relatively severe fractures. This is only about severe fracture dislocations with a major part of the joint being completely destroyed and the tendency to subluxation. So all the mild papers are not, and it's just simply summed up in the methodology as severe selection bias. But I just described it a little more closely, but maybe we did not have them put it down due to like the length of the methodology.
Thank you. But I think this is something we all were just thinking about, if how it comes that especially these 2 very invasive techniques were chosen, and it is good to clarify now in this discussion. So let me check if there are some more questions. Not at all. Maybe from your side. Otherwise, I think we can finish also the second paper and the discussion about the second paper. Thank you to everyone for this great contributions. And then I give the word to Zaf.
Thank you, Leila, and thank you, everybody. Just a final few words from me as we come to the end of the year. This has been our 8th journal club. We've come a long way since the inception of the journal club during COVID, and we've continued to evolve, as you've seen. Our aim has always been to try and educate and inform and have academic discourse, and to do that, bringing the community together from across Europe. On that journey, we've had the privilege of having many experts from around the world who've taken their time out to join us with us on this journey. We've continued to evolve. So as you know, we've started to now have a nation theme. Last time we were co-hosted with Switzerland, and this time Germany, and next time in January it will be Spain. It seems that all the countries being coming out of the World Cup are getting their opportunity to host the Journal Club. So maybe England, maybe after the final, England will come back and host the Journal Club. Let's see about that. But on that journey of evolution, I'm really excited to announce that we are going to start podcasts up from the start of next year. Just as I will draw things to a close, there will be a video about that. All future journal clubs will be available on podcasts, so you can listen to an audio on your way to work or in the gym, however you want to listen to it. And all the previous journal clubs will be uploaded onto podcasts as well. And so all that remains is for me to thank again all the people who have been on tonight's journal club, all the experts on previous journal clubs, and there is a big team behind this journal club that works in between each episode. There's quite a lot of work, and I'd like to thank each one of them. Some of the names you can see in writing on your screen tonight. So special thanks to them. They do all the work behind the scenes as well. And all that leaves me is that there's going to be a video shown after I finish. And I wish you all a peaceful and happy Christmas and New Year, and good night from all of us. Thank you.